translation simultaneously. So we do ask the speakers to please just space themselves to help them with the translation. And as soon as we're done with the first presentation, we will have a 5-minute health break for them before we move over to the panel discussion and the questions and answers. So I want to welcome Dr. David Weber, which was so gracefully happy to join very early in the morning to take us through this. And Dr. David Weber has been in the faculty of University of North Carolina since 1985, and he's currently the Charles Addison and Elizabeth Ann Sanders Distinguished Professor of Medicine, Pediatrics and Epidemiology at the University of North Carolina School of Medicine. And he's got a huge bio sketch. And I think I'm going to leave it over to him to just tell us a little bit of his background before we start. So welcome, Dr. David, and thank you very much for being here with us today. And I'm going to hand over to you now. Thank you.
Thank you very much. Thank you for inviting me to provide this presentation, this virtual tour of my hospital. And it is greatly appreciated. A little bit about myself. I've been here for now a little over 35 years. I serve as medical director of our infection control department, which has about 20 different members in this department, so it's very large. I also serve as Associate Chief Medical Officer for my hospital, which is roughly a 950 bed hospital. With that, I'm going to go ahead and start my presentation. A virtual tour of an academic hospital with a focus on infection prevention issues. So this is a picture of my hospital. Actually, it's a little old. Off to the left, we're now building a brand new large surgery center that's going up as well. And the UNC is an academic medical center. It is part of the medical school at the University of North Carolina and also part of UNC Health. So we are a system with 11 hospitals, 13 hospital campuses, roughly 33,000 employees, 3.5 million clinic visits, 100,000 surgeries, and 5,400 medical staff. We're established in 1952. We are a public hospital, and actually the University of North Carolina is the oldest state public school in the United States, opened around 1796. It does include multiple hospitals within the medical center, all of which are physically adjoined as are listed there, and we have approximately 950 beds. Well, here are the key infection control prevention interventions: appropriate hand hygiene following the WHO 5 moments, appropriate surface disinfection of environmental surfaces in rooms, patient rooms, proper disinfection or sterilization of shared equipment and medical devices, say blood pressure cuffs. You should have separate clean and dirty utility rooms on each clinical floor, ideally. Early identification and isolation of patients with known or suspected communicable diseases such as tuberculosis or these days COVID, Ebola. You need special infection prevention policies for operating rooms, pharmacy preparation rooms, procedure rooms such as where you would do bronchoscopy, and intensive care units. We use standard precautions as defined by the Centers for Disease Control and Prevention with all patients to prevent contact with potentially contaminated body fluids. So that is the use of personal protective equipment, gloves, gowns, mask, or eye protection as needed. All body fluids, with the exception of sweat, are considered as potentially contaminated fluids. In terms of healthcare personnel, we should provide pre-exposure prophylaxis for healthcare personnel with vaccines that prevent acquisition or transmission, and that includes mumps, measles, rubella, varicella, influenza, and hepatitis B for individuals who might have contact with blood or other internal body fluids. And we need to have a system for providing post-exposure evaluation and for post-exposure prophylaxis if available and indicated for exposed healthcare personnel. And what are some of the critical areas of the hospital in terms of infection prevention? Well, first of all, we have all our standard hospital rooms, some of which may not be single patient rooms, but house the patients on the floor. Key to that is obviously the easy availability of hand antisepsis, patient isolation in individual rooms if they have an airborne or droplet disease, and surface disinfection. I already mentioned having clean and dirty utility rooms. We'll talk more about that. Having ideally airborne isolation rooms, which are for airborne diseases such as measles, varicella, chickenpox, tuberculosis, and of course, COVID. These in the United States have direct out exhausted air, greater than 12 air exchanges per hour, and negative pressure. One should have a COVID-19 high-risk containment areas, central sterile processing, where we do sterilization of surgical equipment and high-level disinfection of devices such as endoscopes. Operating rooms need to have a plan for water damage remediation, for safely managing construction and renovation, and for protecting the sterility of drugs in your pharmacy, compounding. And again, I'll talk about all of these and more specifically in a few moments. Well, here's a typical medical floor. You can see, at least at my hospital, 2 different floors, older construction up on the left, newer construction down below with glass doors. I want to point out to you, you'll notice right next to each of the rooms, there's a little device here, right here, that is for our alcohol waterless hand hygiene. Also notice on the door, this has a contact isolation sign. And you can see, because they're on contact isolation sign, there is a little cart here with that has gowns you can see here, gloves and disinfectants for that contact isolation. And those products should ideally be readily available. Certainly you can use soap and water, or water as an antiseptic such as chlorhexidine, but alcohol tends to be easier, faster, and ideally that should be made available. This is some of our data generated by my colleague, Dr. Sigbert Bennett, and it shows that if you go from very good hand hygiene, in this case, 82.6%, and this is based on our now more than 1 million observations. We use a little app so people can assess hand hygiene and colleagues, and you go up to here 96%. So from good to very good, actually your infection, your rate and number of healthcare-associated infections falls. So hand hygiene, clearly one of the key standards and interventions for preventing healthcare-associated infections. We also use, in addition to standard precautions, we use transmission-based precautions, all defined by the U.S. Centers for Disease Control and Prevention. Droplet precautions for diseases such as pertussis, meningococcus, influenza, which require use of a surgical mask. Contact precautions for diseases such as norovirus and C. difficile, multi-drug resistant organisms such as MRSA or CRE, and we use gowns and gloves. Enteric precautions, which of course are a combination of contact isolation, but special hand hygiene. We use this for norovirus and for C. difficile because those agents are not susceptible to alcohol. So the only difference between contact and enteric really is the use of washing your hands in soap and water, or water and an antiseptic. And finally, we have airborne precautions for diseases such as measles and tuberculosis, which in our hospital require the use of an N95 respirator. Of course, we do have what we call special airborne precautions, which are a combination of our airborne precautions plus contact precautions, and we use those for COVID. I want to talk a moment about the role of the contaminated room surfaces in healthcare-associated infections. Here's, of course, our typical room in our hospital, bed, a little couch. Actually, it folds out so a visitor could sleep there overnight, a little desk for charting by our healthcare personnel. Surfaces are frequently contaminated. Approximately 25% of the time, you can find a pathogen that the patient had if it's a multi-drug resistant organism on the surface. We know some of these healthcare-associated pathogens can persist for days to weeks, and in the case of C. difficile for months. This includes MRSA, VRE, Pseudomonas, and Acinetobacter. It would also include multi-drug resistant enteric organisms such as E. coli. Contact with these surfaces results in hand or glove contamination for the healthcare provider. When the patient leaves the room, we do what's called terminal room cleaning disinfection, because you have to wipe every surface, and that's both difficult and surfaces can be missed. We know that this often leads to continued room contamination, and anywhere from 10 to 90% of the time. We know evidence demonstrates that these contaminated surfaces lead to healthcare-associated infections and colonization of the next patient who enters the room if the previous patient had a multi-drug resistant organism. And we know that surface disinfection reduces contamination, which then reduces the risk of healthcare-associated infections. So ideally, of course, when the patient leaves the room, you do a complete terminal disinfection, means stripping the bed, all new sheets, and wiping every touchable surface. And ideally, hospital rooms should be cleaned and disinfected at least once daily. Here is an example on the left of our housekeeper having already cleaned the rooms, putting on clean sheets. And on the right, you can see her cleaning cart, disinfection cart outside with all the chemicals on top. You can see that she's wearing a mask inside and scrubs while after she's cleaned the room, now putting on clean sheets. You'll notice to the right of the room is a counter with some material, sink for hand hygiene, and we have multiple sinks on each floor, although we have the alcohol hand hygiene products next to every single room. You can see that to the left. I also want to point out to you that this little vertical panel here next to the sink and the disposal is called a splash shield, and that's water splashing from the sink, which might be contaminated, doesn't contaminate items that need to be clean and or would contain something that would be a wrapped sterile item that would be on the counter. So we have these splash shields next to each sink if they're next to a countertop. Other important surfaces, up in the upper left, curtains are frequently contaminated with multi-drug resistant organisms. There are possible solutions. One is the use of disposable curtains. You could use antimicrobial containing curtains, although that really has not been validated. What the simplest thing to do is what it would be routine disinfection of the so-called grab area. People don't touch the entire curtain. They touch the edge of the curtain and then they pull it closed. And that can be cleaned as we do by spraying it with an improved hydrogen peroxide product. So that's how we disinfect our curtains. Certainly you can use disposable curtains or periodically launder curtains, but that is more difficult and more expensive. In the upper right, you can see a patient in a wheelchair, and shared patient items may transmit to multi-drug resistant organisms between patients. You can assess how well they're cleaned by using fluorescent dye or ATP with feedback. You can use UV disinfection, or you can just simply wipe the items with the disinfectant, which is what we do. On the lower left, the floors have been now demonstrated to be contaminated with multi-drug resistant organisms. The role this plays in transmission of those organisms from room to room, because we don't really touch the floors, is still being studied. But they can lead to a contamination of shoes or socks to dissemination. And really the solutions are education of our environmental service workers, use of a disinfectant on the floors, or when the patient is out of the room, ultraviolet decontamination of the room. Finally, on the right, you can see chairs in the patient room for either the patient or family to sit on, or visitors, or for healthcare providers. It's now known that fabric-coated chairs may be contaminated with multi-drug resistant organisms, leading to transmission among patients. And really the simple solution here is use only non-porous furniture in hospitals to facilitate cleaning and disinfection. We do not allow any fabric chairs in our patient rooms or in our clinics. Rather, they are solid plastic, or you could use wood or steel, but something that's easily disinfectable. So here is our surface disinfection bundle. You should standardize cleaning and disinfection of patient rooms and shared equipment devices throughout the hospital. Since many times environmental service will clean certain things, but nursing equipment such as infusion pumps, EKG machines, and others, you need to develop a checklist who is responsible for cleaning and sterilization disinfection of each room surface and device. And this has to be unique to each part of the hospital. So what's done in the emergency department or the pediatric intensive care unit or an operating room are different. All touchable room surfaces should be disinfected daily when spills occur, when surfaces are visibly soiled. Terminal disinfection when the patient's discharged from the room with complete cleaning and disinfection. Non-critical medical devices should be disinfected daily and when soiled. Clean and disinfect sink and toilet daily. Damp mop the floor with the disinfectant detergent whenever there's a spill or a terminal disinfection. If you're using a disinfectant that's not pre-prepared, but preparing it on site, make sure and document that you have the correct concentration. If you're using disinfectant wipes, then make sure that you are using that for the correct amount of surface. You can't wipe an entire room with a little wipe. Ideally, per the CDC, you should monitor cleaning effectiveness. We use fluorescent dye with immediate feedback, and you should consider the use of room disinfectant devices such as ultraviolet if they're available for patients who have multi-drug resistant organisms. People cannot be in the room at the time that's used, so this could not be used in a multi-person room. So some of the no-touch methods that we're beginning to introduce in the United States and other parts of the world are UV devices and hydrogen peroxide systems. The advantages are demonstrated to decrease microbial contamination on surfaces and medical devices. The ultraviolet light has been demonstrated to reduce healthcare-associated infections. It eliminates human failure to disinfect all surfaces and is residual-free and safe in the environment. The disadvantages, you still need to physically clean the room. The purchase costs are substantial and may not always be possible in many parts of the world. They cannot be used with people in the room, and it does slow room turnover. In terms of preventing transmission of airborne pathogens, I mentioned that we put them in airborne isolation rooms. Most of our newer rooms in the United States also have an anteroom, and this shows per CDC guidelines the directional flow depending upon the type of patient in the room, such as immunocompromised. We use this for measles, chickenpox, pulmonary tuberculosis, and other highly communicable diseases, including COVID-19. And the use of an airborne isolation room for patients and proper use of personal protective equipment is key to protecting our healthcare personnel and other patients from acquiring these diseases. I've already mentioned the US room standards, and the personal protective equipment is an N95 respirator. For some diseases such as COVID-19, we would add an eye protection, either a face shield or goggles, or an air purified respirator could be used as well. Here is an example of one of our airborne isolation rooms here to the left. To the right is the entrance into our anteroom. Again, notice the alcohol waterless wash. Here is the anteroom. You would go into the anteroom, put on your personal protective equipment, wash your hands, and then enter the room. The room is at negative pressure with the anteroom. The anteroom is positive pressure with regard to the isolation room as well as the corridor. This is a simple way, by the way, of telling if a room is a negative or positive pressure. It's the so-called tissue test. It can be done anywhere. You just take a 1-ply tissue. This is me, I'm holding the tissue vertically, but you see it's being pulled into the room, demonstrating the room is negative pressure. Air is flowing into the room with the door closed. If the tissue was blowing away from the room, it would be positive pressure. And if it was hanging down vertically, it would be even pressure. This is a very simple way of testing and very accurate pressure relationships in a room. This is a clean utility room. No contaminated materials are allowed in this room, so you wouldn't have portable toilets or waste products in this room. This is where all your clean equipment and things such as bandages would be stored. You'll notice all the shelves are wire mesh to prevent dust buildup on flat surfaces, so the dust would fall down onto the floor. You'll notice the bottom floor is above, the bottom shelf is above the floor, so you can actually wipe under the floor. And the top shelf is below the ceiling, so as not to obstruct the fire suppression system that we would have. This, on the other hand, is a dirty utility room. Notice the big difference. There are no clean or sterile supplies allowed in this room. There's a hopper or a toilet here in the corner for disposing of liquid waste, such as urine. Hand washing sinks should never be used to dispose of body waste or contaminated fluids. They go down a toilet. Again, you'll notice a sink to the right and a splash shield to protect equipment there. So we would use this. So ideally, you would have a clean and a dirty utility room on every floor or location where patients are managed as inpatients. What about COVID units here? Key issues in a unit is really, and this wasn't designed as you want a cold area where you have treatment and patient there, people coming in and gowning, and then you have a hot area zone where you have a warm zone where things could be contaminated, such as taking off personal protective equipment, and then the hot zone where everybody needs to be gowned in personal protective equipment. Some of the key issues for highly communicable diseases are, and this would depend on whether we're talking about Ebola or SARS-CoV-2, environmental survival, germicide susceptibility. We talked about in your special units, you need to have a cold area, a warm area, and a hot zone. You need to understand the personal protective equipment there. At my hospital, we also use personal protective PPE monitors to help people make sure they put on and take off their equipment correctly. And we've not had any transmission of COVID to our healthcare providers in these units, despite taking care of thousands of COVID patients. You need to understand the pre and post-exposure prophylaxis if it's available. Now for COVID, we do have COVID vaccines as pre-exposure prophylaxis. In terms of labs, recommended biosafety levels in the lab. So for Ebola, that's 4, which means you really do not want to be sending blood down to your labs unless it's been decontaminated, and you will need to understand the recommended waste disposal. Here, for instance, is our COVID unit. This is the hallway. You can see all the signage, so people do not enter if they're not prepared. Looking now into our area, this is the cold zone where people are prepping, and you can see the equipment and our shelves with gowns and gloves, and then you're moving into the hot zone over here with lines demarcated there, and again, hand hygiene and 95 masks only. So again, you need to have clean, warm, and hot zones for COVID units and other highly contained units. In terms of pandemic planning, one needs to consider locations for evaluating and treating patients with highly communicable diseases as outpatients as well. And we have designated areas that we've of our hospital. This is our infectious disease clinic, where we designed for that. Each of these rooms here can be set for positive or negative pressure. They do all meet airborne isolation rooms, and ideally you'd want those units to have direct entrance into the hospital as opposed to have to walking through the hospital and potentially contaminating it. Let's turn now to central sterile services. It's divided into 3 zones, much like we talked about, to accomplish the functions of decontamination of surgical instruments and other contaminated devices, assembly and sterile processing, and then storage. And so you start here with transport, cleaning, disinfection, inspection, packaging, sterilization, transport, storage, and then use. So it's a continuous circle. So you need a decontamination zone, the assembly zone, and storage zone. A distinct separation should be maintained between the soiled and sterile areas. The technical staff who work on either the soiled or sterile area should not cross from one area to the other, and there should be directional airflow from clean to dirty, not the other way around. So here is our area where the instruments would arrive, and you can see they would be cleaned here, disassembled, cleaned, and decontaminated. People in these units would be in full personal protective equipment. From there, they would go through our washer disinfector here, which eliminates manual cleaning, and washer disinfectors are very efficient in eliminating large numbers of contaminating items, including spores. You can do it manually on the left, or ideally use an automated method. From there, they go into the room, now clean, where they would then be put into our steam sterilizers or our low temperature sterilizers. Steam sterilization is the most robust method and is preferred, but some items are temperature sensitive and you would have to use a low temperature method. But the low temperature methods require meticulous cleaning and adherence to all the guidelines because they're much less robust than steam sterilization. And then finally, once they're cleaned, then they are put onto our racks, and you can see all the similar items there. And then they're assembled into trays. At the same time, they're observed to make sure there's no damage or problems with the individual instruments that are going to be used for surgery. And then finally, once those instrument packs have been assembled and sterilized, you can see here, then they're stored again on mesh shelves to prevent contamination, accumulation of dust, and they can settle down. You notice they're all on wheels, so they can be moved for proper cleaning, and then we have transport carts. The shelves for storage are open, but the transport carts are closed, and those would then be moved to the operating room. We have a satellite pharmacies there, and this is preparation for our pharmacy there. So again, this is another sterile area, much like operating rooms. You can see here is the clean area here. This is the warm area. People can wash hands when they come out. They can dress and gown before they go into a little court in this area. Then they would enter into the sterile preparation areas. We actually have two areas here. I'm looking through to one. You can see here is this little corridor that you saw to the left, and there's another one behind. We have one room for hazardous chemicals, such as chemotherapy, and one for non-hazardous chemicals. You can see that there's special air handling in the entire room. Actually, it's all HEPA filtered and large airflows, but then there are special hoods. Everyone is wearing personal protective equipment, including gowns, gloves, hats, and masks, much like they were in the operating room. And this is where we would be doing our compounding of sterile pharmaceutical products, and we need to maintain sterility there. In terms of the operating rooms, again, signs about special entry. Personal protective equipment is required to enter the semi-restricted zone. This is the corridors outside of the operating rooms, but inside the operating suite. Here you can see on the right somebody with they have on shoe covers, they have on a hat, and they have on scrubs, and they would have on a mask there to enter that zone. Additional PPE would have a mask if you're going into the restricted zone or if there are sterile open trays. Here, the OR is a sterile area, again, within the sterile surgical field, certainly sterile gowns and gloves, pre-surgical scrub of the healthcare provider's skin. All facial hair is covered. That's certainly a cap, but often if people have mustache or beard, that needs to be covered as well. Shoe covers and eye protection. And the operating room should be designed to be easily cleaned and disinfected. All the equipment, clean and sterile equipment, you notice is in closed cabins. Sterile trays should be opened just before surgery. Notice everything on the actual floor is on wheels, so they can be moved for complete cleaning of the floor. Again, we come out of the operating room, we go into our post-acute recovery room, and you can see here, these are the bays the patients would be in with the medical devices for such as EKG machines. But we also have isolation rooms in our PACU for patients requiring contact, droplet, or airborne isolation, such as COVID or tuberculosis. So even in our recovery rooms, we need to have special isolation rooms. What about water damage and remediation? So this is where we had a water leak, and you can see here the damage, this black material in the before we did any remediation is mold. To the right, anything that has mold on it that's porous, such as wallboard or asbestos material for maintaining cooling and heat, needs to be removed. You go all the way down here, as you can see here, to steel and floor. So everything that's been damaged has been physically removed after the water damage. Then everything has been repaired, and then there needs to be complete cleaning afterwards. So it's critical that anything, again, that has mold damage or substantial water damage, if it's porous, needs to be removed. What about renovations? Again, after sewage intrusion, flooding, or other water damage, close off the affected area immediately. Ensure the sewage system is fully functioning. If hard surface equipment, floors and walls remain in good repair, they should be dried within 72 hours using large fans and then disinfected using standard cleaning procedures. And everything should be allowed to dry thoroughly before restoring varnish or other surface coatings. You need to contain dust and debris. We'll talk about that. And regardless of the original source of water damage, you need to remove wet, absorbent structures, carpeting, wallboard, wallpaper, and cloth furnishings that cannot be easily and thoroughly cleaned and dried within 72 hours. These are all, again, CDC guidelines. This is a newer picture of my hospital. You can see there's some construction out here in front of the hospital. And so one needs to be very careful about any patients walking through around those areas to get to the hospital, need to be masked, and you need to make sure that your hospital has appropriate filters to keep contaminated dust from entering the hospital. Here is inside a renovation area, nice and clean and well maintained. There have been many, many outbreaks, as you can see here, of fungal outbreaks, aspergillus or mucor with construction and renovation. So when you're doing demolition of walls, removal of flooring and carpeting, working with sinks and plumbing, opening ceiling spaces, crawl spaces, or repairing water damage, you do need to be assuring safety of the patients using remediation techniques. So here is a construction area, sign "Don't Enter," and you can see here again, we have a mat to take dust off the floor before people go in. They should check with the superintendent. Once you go into that area, we usually use large machines, HEPA machines, to keep the dust down. When we do enter a ceiling, if this is in a patient area, we use these little mobile carts there, and this was just recently published, and you can see one of the workers going in. They go in, they close the door, they extend the plastic up to the ceiling, they then go in and do their work. There is actually a HEPA filter here, so all the air is filtered. They would close and the ceiling, and then they would give a few minutes for the HEPA filter to clean the air before they opened the door. We've actually done studies, so you can see here inside high levels of fungi, but outside very low levels, thanks to the use of this mobile cart. In the United States, we use a risk mitigation, and we group things into these different groups here based on patient risk and construction type. You get different colors in this then, and I've given you the references. Gives you the type of remediation efforts that you need to do for doing both construction and new and when you're doing when you're building new facilities here. Key are hospital epidemiology, infection prevention should be notified before any renovations or construction. This is called an ICAR, and this is what we use, this type of analysis for all construction and renovation, and this is done in conjunction with the engineers and with infection prevention. The goal is to prevent airborne dissemination of spores. We need to protect not only the areas horizontally next to construction, but also vertically above and below. And we visit these construction areas every single day to make sure they're adhering to our standards. So thank you very much for allowing me to present a tour of our academic medical center. We are devoted to excellent patient care, research, and teaching. And I hope you found this little view of our hospital instructive. We review these activities every day at our institution. We're always seeking to maintain what we do and improve upon what we do. And I certainly want to thank all the infection preventionists and hospital epidemiologists, both my institution and around the world, for everything we do to keep patients safe. Thank you very much.
Thank you very much, Dr. David. I'm just going to give us a 5-minute break for the interpreters to just catch their breath. There's quite a lot of questions on the Q&A that Lizzie and Dr. Wandy will take us forward as soon as we have this break. We can have a small panel discussion with the panel on the call. We've got Silas from CDC and then Jacob and Maureen from Uganda as well. But 5-minute break from now, so it's now 12:36 here on my side. So if we can start again at 12:40 or 13:40 East Africa time. So just a quick health break for them. Thank you. I think you can get a glass of water, Dr. Yes. Quite a lot.
I actually have one right here, and I'm looking forward to the panel.
Thank you. Welcome back, everybody. It's now 12:40 or 13:40 East African time. I'm just going to hand over to Lizzie. Lizzie is also from ICAN, Lizzie Masibuku. She's currently in Uganda. Lizzie, if you can take it forward, and then Dr. Wanda, I know, is juggling 2 different meetings. If you want to jump in as well, please go ahead. Over to you, Lizzie.
Thank you, Anna, and thank you, Dr. Weber, for the wonderful presentation. And welcome to the team of our panelists on this question and answer segment. To start with, it was a comment on the IPC issues that as a continent, we are most of the time seen being reactive than proactive. And this has been noted, and I would like to kindly ask Anna and Dr. Wandy just to give a summary of some of the initiatives that we are doing as a continent to address IPC issues, so that we move away from being on the reactive side and start being proactive. Over to you, Anna, and Dr. Wandy, just a few comments.
Thank you, Lizzie. Dr. Wanda is in the other meeting, so I'm going to talk on behalf of both of us. If I forget anything, she and Silas can maybe jump into with this. From ICAN's side, we work from Cape to Cairo, and we are passionate about IPC. We want to transfer knowledge, and we've got different courses that we actually run. And since the pandemic, we joined forces with Africa CDC and Africa Union, and we started this webinar series where we do a 6-week, 1.5 hour per week, where we touch on IPC specific topics, specifically related to COVID, but also to the norm of IPC, trying to ensure that IPC is not just during a pandemic or an outbreak, but that IPC becomes part of our normal day of life. And I think this presentation really makes us sit up as well to understand that, it should be there every single day, every single time, with every single patient as if they are infectious, and making sure that we are transfer that knowledge to all our healthcare workers. Just because we are in healthcare doesn't mean we all understand IPC or where IPC fits in. And I think that is something that we're really working towards. And a lot of new guidelines have also come out from IPC and from Africa CDC, and we've got a whole working group that we work on different research on logistics and on also PPE, manufacturing and standards. So there's a huge amount of work that went into since the pandemic, and we hope to make sure that this, moving forward with this on a continuous basis, that we will prevent another outbreak or another pandemic from ever happening again, if we can just ensure that every single person takes this knowledge and move forward and make it part of their own everyday life. So I don't know, Silas, if you want to maybe add anything, or Jacob, if Dr. Wanda is able to talk, she can maybe say something as well. We work in different countries in Africa. We do have different projects with different stakeholders. We also work very closely with WHO and CDC Atlanta, with ICAN and Africa CDC, and stakeholders like Resolve to Save Lives, WaterAid, and all of them. And we take on the different needs in different countries, and we see how we can help. Thank you. Over to you, Lizzie, or anyone else that wants to add anything.
Thank you, Anna. Anyone else wants to add anything from the panel? Jacob, Maureen?
Thank you, Lizzie. It's Jacob from Cameroon. I think what Anna has mentioned about training is very critical. From my experience, managers sometimes reject some things, or do not approve some things, or do not provide some supplies or material because they really don't know the importance of some of those things. And until you give them the knowledge so that they can be able to understand the importance of IPC, how it works, then they will be able to truly identify with you. What we've done at the level of my organization, Cameroon Baptist Convention Health Services, is that we consider training for all levels of people, including managers, clinicians, and so on and so forth. So always include them, the managers, in your trainings. And once they understand the importance of IPC, they will join you in advocating for IPC, and they will also ensure that any supplies that are necessary are actually provided in time. Thank you.
Thank you, Joseph. Oh, sorry. Thank you, Jacob. The next question is on the issue of the masks. It is, hello?
Dr. Wandy, I just want to say something quickly.
All right. Over to you, Dr. Wandy.
Yes, thank you very much, and good afternoon, good morning, colleagues. This is Dr. Wandy Alimi from Africa CDC. Just to reiterate the fact that as a continent, we have definitely recognized the urgent need to support countries with building and strengthening the capacity around IPC at healthcare worker level, as well as management and administrator level. So one of the things that we are really trying to do is, through the best practices and lessons learned from COVID, is how to institutionalize this training such that we have institutions of great expertise and capacity to start to conduct all of these trainings that are focused to the needs of our continent. So I think just for your awareness, we are looking to ensure that this is a more sustainable means of building capacity of healthcare workers across our member states, and definitely working with other partners, as Anna has already mentioned, to strengthen the IPC capacity across the member states. Over to you, Lizzie.
Thank you, Dr. Wandy. Our next question is on the issue of the masks. And the question reads, how effective is copper oxide medical mask in treating patients with COVID or when performing aerosol generating procedures in the intensive care unit? Over to you. Welcome, Prof. Shade.
Thank you very much. I really don't have any particular data concerning how much more efficient or not. I do know that copper is known to be bactericidal. So just using common sense, it should, but I really don't have the evidence to be able to make any pronouncements on that. Thank you.
This is Dr. Weber. I can make a few comments if that's okay.
Yes, please.
So we have studied both copper in general on surfaces, and we have, through our aerosol engineers, studied how well masks work to prevent inhalation of small particles, such as you'd find aerosols from COVID. First of all, copper is broadly antimicrobial. But one, it is very slow acting, and two, it only really reduces the number of organisms by 1 or 2 logs. So it really would not be very useful to put it in a mask to prevent COVID because it might be fine on a surface, but it would act too slow to inactivate SARS-CoV-2 as it passed through the mask. In terms of medical masks compared to an N95 by definition will filter out 95% of the particles of the size that would be infectious before you would breathe them in. And the filtering of any mask really depends on 2 things. One is the filtering through the material of the mask, and second is preventing flow around the mask. So just by achieving a better fit of any medical mask, you substantially improve the effectiveness. So a medical mask, somewhere around 40 to 50% at baseline compared to an N95. But by some very simple ways, you can get a medical mask so it's an 80+% effective, which protects you against almost all infectious diseases. And the way to do that is to either tie some knots right where the straps come out of the mask, or to pull the mask tighter behind your face, just with hair clips or other ways there. And I can certainly send you an article, or you could look up my name and you'll see the published papers that we did. We do believe, and we use medical masks for all of our patient care, with the exceptions of taking care of a known or suspected COVID patient or for aerosol generating procedures when we do use an N95 mask, respirator. And so we've certainly had a number of healthcare providers who took care of a patient that we didn't know at the time had COVID. None of our healthcare providers have acquired COVID as a result of that exposure. So medical masks are very, very safe, but some very simple ways improve it. Alternatively, you can put on a medical mask and then put something over it, such as a gaiter or a cloth mask, anything that helps pull it tighter. If you are going to use double masking, though, then you should put the medical mask on first. But the best double masking is to have all of your patients and visitors in the hospital, plus all of your healthcare providers masked, what we call universal pandemic precautions, at all times when you're in your healthcare facility. And that is very effective in preventing transmission of SARS-CoV to our healthcare providers. Thank you.
Thank you, Dr. Weber. Right, the next question is directed to you, Dr. Weber, and it's on the disinfection of curtains, where you mentioned that you spray using hydrogen peroxide. And the question is, how do you limit the aerosol generating with the spraying? And since the WHO guidelines discourage spraying before cleaning, how do you balance the two? Over to you, Dr. Weber.
Thank you very much. So there really is there is no way easy on a curtain, which is porous cotton or linen material, to actually put something on the surface the way we would do a solid surface with a wipe, for instance. So it is a balance, and the improved hydrogen peroxides are very effective microbicides. And we have not found in our studies that there's a concern, and this is the only time we're spraying something. We spray just the grab area where the hand would be. And the reason we chose hydrogen peroxide is you don't want to be spraying into the air something that is caustic or will cause people with asthma or people to cough. So you really can't use something like quaternary ammonium compound, for instance, or a phenolic, things that we often use for surface disinfection, whereas hydrogen peroxide has a low toxicity ratio. And this is the one area we use it. And we do feel that, and this is not an area that should be having SARS-CoV-2 on it. So we do believe that it is safe to do, and it is actually beneficial for this one area. Alternatively, as we said, you could, if you were concerned, you could use disposable curtains, or you could take the curtains down and launder them. Both of those are costly and difficult. So we found in our studies that the use of the hydrogen peroxide was safe.
Thank you. Thank you, Dr. Weber. As you take a breather, my next question is directed to either Maureen or Jacob. The instruments for sterilizations, which is used in the clinical areas. So after use at the point of care, where is the decontamination and cleaning done? Is it within the CSSD, which is the Central Sterile Supply Department, or you do it somewhere else? Over to you, Jacob and Maureen.
I'm sure Maureen can go ahead. I don't have any experience at our level to share. Is Maureen there?
I think Maureen dropped off.
Okay,
yeah,
Anna. All right, Anna, would you like to tackle that one?
Yeah, what we normally depends on what type of instruments, but if it's for a surgery, you would be able to take it to the CSSD in a closed container where they then start in the dirty area by cleaning, disassemble, and then take it through the wash disinfecting. If you have that, like Dr. Weber explained, and then go through the sterilization department. It depends on if it's a hospital or a primary healthcare facility, but they should have a separate room where they can take and clean the equipment, and then making sure that they do have the space and the ventilation and also the right PPE. That's just a quick take from my side, but I think Dr. Weber and Prof. Shade would also be able to maybe comment on that from their side.
I agree. Certainly the last thing you want for any sterile equipment that has blood or tissue or body fluids on it is for that to dry. It makes it much harder to clean. So ideally, once any device is used, it's put into a transport tray, and it at a minimum you could put it in just rinse it in water and put it in the tray and keep it wet, or you can spray it with materials that keep it moist and usually have some enzymes in it to help. And then you want to transport immediately or as soon as possible to an area where it can be thoroughly cleaned and then sterilized. But you really don't want instruments left overnight in either a procedure room or an operating room and allowed to have blood or materials dry on them, because then they become much harder to clean. Thank you.
Thank you, Dr. Weber. Any additional comments from Prof. Shade? Now we can move on. The next question is, I'll also send it back to you, Dr. Weber. It says, may you please explain what non-touch decontamination entails?
So for decontamination, obviously before, while it's still contaminated, everybody should be wearing gloves, and one needs to be very careful about obviously not cutting themselves on instruments that are sharp. You have to be very careful. So first of all, besides wearing gloves for anything that's contaminated, it's best to be using some type of devices to help take razor blades off or handle other sharp instruments until they've been through, at least through the washer disinfector to remove the great majority of any pathogens. Of course, if there's any chance of splatter of water or other materials, they should be wearing gowns and face shields or eye protection as well. Thank you.
Thank you, Dr. Weber. And the next question is on waste management. It says, could you kindly shed more light on how you manage your healthcare waste within the wards? So I will throw that question to anyone on the panel. See, Maureen, you are back.
Thank you. Thank you very much, Lizzie. Sorry, I'm logged in as somebody else. Yes, and the question was on waste management. Really, the previous guidelines we have received, and even the discussions that we've had on this webinar are really exactly what I would say in terms of the different categories of waste that we have within the healthcare setting. Maybe Lizzie, if you could re-echo that, was that question specific for COVID-19 waste or general medical waste? Back to you, Lizzie.
I think we can talk about the general medical waste. Prof. Shade, may you kindly mute your mic?
Oh. All right. Thank you. Thank you, Lizzie, for that clarification. Yes, and as I was saying, I'll just build on what I said earlier. The general waste IPC guidelines that we have in country and also in other countries really apply in terms of non-infectious waste, infectious waste, highly infectious waste, as well as the pharmaceutical waste and all the others. So the recommendations really, depending on the health facility for where the person that asked the question is working, at very low level healthcare facilities where there is no incinerator. For example, case in point in Uganda, for most of our lower level health facilities, we do not have incinerators. So what we have been encouraging from the perspective of IPC's burn pits for facilities, for healthcare facilities to dig burn pits so that the waste is burned every day every evening to take care of that, not to have it littered around and being being disastrous to the community. But with the presence of incinerators and facilitated by proper segregation, knowing that 85% of the waste will be non-infectious and only 15 to 20% will be infectious, needing incineration and other waste disposal practices, it should be easier or much cheaper to safely, if segregation happened right from point of generation to the point of disposal. So here in Uganda, we have several categories, and I know that these apply for the black, yellow being infectious, the red being highly infectious. And this is what we are using here in Uganda, sharing the experience here. And I know that the same colors apply across many nations. So I hope I've sufficiently answered that. And if not, I know that we have had a webinar on that. It can be shared for the person that asks to be able to go through in detail. Back to you, Lizzie.
Thank you so much, Maureen. You really did answer it in detail. The next question is to Dr. Weber. Is fogging or misting used as part of a disinfection process in the USA? If it is, what are the chemicals used? And because there's, oh, sorry, that one is being answered by Anna. Apologies for that.
Hello, Lizzie. Lizzie, I'm just
yes,
writing
Anna.
people answer in person so you can respond.
All right. Sorry, over to you, Dr. Weber. Is the fogging or the misting used as a disinfection process in the USA?
The answer is no. We don't use fogging for disinfection. We generally prefer disinfectant wipes. That's the most commonly used. Previous to the use of pre-prepared wipes, we would use chemicals and put them on some type of cloth and then do the wiping that way. We do have the ability to use UV light for terminal disinfection for patients who have had multi-drug resistant organisms, but we don't use fogging anywhere in the US for any purposes.
Thank you so much for that response. And the next question also directed to you, and your presentation, you mentioned on PPE monitors. May you please explain how these PPE monitors work?
Certainly. So we have studied here in the laboratory where we put people into personal protective equipment, gowns, gloves, masks, and eye protection. And then we would put a non-human virus on the gowns and gloves and ask people to take them off following the guidelines by the Centers for Disease Control. And we often found that people contaminated their skin or clothes by not following the exact procedure to take them off. Particularly important for diseases such as Ebola, highly communicable contact diseases. So what we have done is we have based on the Centers for Disease Control, the way you put your personal protective on to make sure that, say for Ebola, every piece of your skin is covered, and the way you take it off to make sure you don't contaminate everything, and that's done in a very specific order. And we have trained our people to do it, but it's very hard when you've been tired all day and you're coming out of, after an hour or two of working with the patient, or you're going in to miss a step and not do it exactly correctly. So we've trained personal protective monitors. These have been often our nurses, but they don't have to be nurses. And they're trained by watching videos and watching them. And their goal is just to stand there while a person puts on their equipment and takes it off, and watch each step, and sometimes read it out to the person and watch them to make sure they don't make any errors in taking their equipment on or off. If they do, then they have guidelines for remediation, such as immediate hand hygiene with an alcohol wash if it's appropriate, for example. And this has dramatically decreased, we find, any errors in putting on or taking off the equipment properly. And we do have such people in each of our COVID units here in the hospital. And as I've said, despite taking care of thousands of patients, we've not had any transmission from the patients to our healthcare providers. Thank you.
Thank you so much, Dr. Weber, for that. And just before I allow you to take a breather, I will going to ask you one more question. It's to do with sorry, I think that one has been answered, but well, let me pick on another one. Just a minute. Says, is the fumigation recommended for ICU? And also the second one is, may you kindly explain in detail about the multi-drug resistant organisms? Thank you, and over to you, Dr. Webb.
Thank you. Yes, again, we don't use fumigation or any aerosol way of cleaning at all. It's all direct contact surface disinfection, with the exception of, as I mentioned, of the curtains. We use the term multi-drug resistant organisms in the United States to refer specifically to methicillin-resistant Staph aureus, vancomycin resistant Enterococcus, and multi-drug resistant gram-negative organisms. Our definition, our working definition, would be any enteric organism, E. coli, Klebsiella, Enterobacter, that produces extended spectrum beta lactamases, or is carbapenem resistant. Or we also would say for our gram negatives, they have to be susceptible to at least 2 classes of antimicrobial agents. So for things like Pseudomonas or Acinetobacter, they have to be susceptible to 2 and ideally at least 3 different classes of antimicrobials. Otherwise, the patients would be placed on contact isolation to help reduce the transmission from patient to patient. Thank you.
Thank you, Dr. Weber. As you take a breather, my next question is directed to Anna. May you comment on the opportunities for mentorship and collaboration as people seek to learn and implement IPC interventions at the various hospitals where they serve?
Thank you very much. Yes, I think this is a great opportunity, and I think if we can ensure that the mentors that we choose, and I'm sure there are so many of them, that we can actually just all give the same message over. I think important with mentorship is that this is the reason why we want to have that all our facilities, to ensure that people know where they are going wrong or how to help them to think about a solution, to think sometimes outside the box, especially in our low to middle income countries and restricted resources countries, that sometimes it's not possible to have all the nice things we see in USA and Europe, but what can we do to make it the best possible way for the patient with the limited resources? So mentorship, yes, ICAN and Africa CDC and our other partners, we're working quite closely together to establish that and to ensure that we follow through by making sure that the mentor can take the time to spend with the person in a facility. And I think it's a good opportunity to have the IPC focal person dedicated to IPC by being able to be a mentor for link nurses, setting up a program, doing regular training, and ensuring that everybody knows what is happening. Thank you, Lizzie.
Thank you, Anna, for that.
Lizzie, can I just add a little thing to that?
Thank you, Prof. You may go ahead.
Okay, thank you. What I find is the difficulty is that invariably when we're talking about training, we just train and we don't mentor. So we find that the difficulties that people have is that there's an assumption by trainers that once you've trained them, they will be able to practice. And the mentorship bridges that gap. And I think it's very important that people who are training themselves should see how well they do things. We recently did a training where we got the people training to go through a process of doing some of the things they were supposed to know. And they found how difficult it was to translate training to practice. So when we're talking about mentorship, following up after training, it's so important to watch the people who you're training and give that feedback as they're doing it in a non-judgmental way, so that you recognize that your training goes beyond just giving some lecture, but that you have to follow through. And I think that really needs to come through when people are, trying to set up programs in their facilities. Too many times we stop at lectures. We don't follow through to see that when they're doing things, we're there at the points when they're doing it to put them through. So I think we must start making sure that whatever training we do is really not complete till we monitor to make sure that they are doing it. It's all in the books, or somehow we have not imbibed it. And if anything we can do is to take that away as focal points, that just telling them what to do does not work. I mean, we all know it, but it's important that we really, really, really work on it in our facilities. Thank you very much.
Thank you.
Sorry, Lizzie, I just want to reiterate what Prof. Chade said. I think that is one thing that, and when she mentioned that to me, I think it's important is that going back and making sure that people did understand and be non-judgmental, that we making sure that people understood, because just to have the book knowledge is not always going over by transferring that knowledge to the rest. Thank you.
Thank you so much, Anna, and thank you, Prof. Chade, for that, and especially highlighting the issues of training and the role which, the critical role which mentorship plays. I'd also like to kindly ask the panelists to be also tackling in some of the questions in the Q&A and be typing the answers, so that at least by as we round up, most of the questions would have been answered. So my next question is directed to either Maureen or Jacob. It's about the WASH issues in the limited resource settings, whereby getting to implement some of the guidelines concerning WASH or IPC is a challenge. So the question is, the PPE usage depends on the areas of working department to utilize accordingly. So in the settings where you have been, is this still working, or you have found other ways of getting to adapt? And kindly share with the participants. Over to you, Maureen and Jacob.
Thank you, Lizzie. I'm Jacob. I think the introductory statement is we need to also maybe reconsider it. IPC WASH generally doesn't depend on the facility, but it actually depends on evidence. And the guidelines always has minimum standard, and the minimum standard generally are based on very small facilities with limited resources. So I think that the first thing to implement IPC and WASH is first to understand what it is all about, and then secondly, to be committed to ensure that things are done the right way. So every facility can be able to meet minimum standard, at least, that we can be able to provide care that is safe and acceptable. So I think that one of the things which I have found to be a problem generally is that sometimes we don't know those needs, and we don't consider them at the time we are setting up a health facility. And then the other thing I would also like to propose is that generally, there is no facility that will have everything that they need, even including those in advanced settings. But what you need to do is to always look around you and see what you have, and some of the things you can adapt some of the things to serve certain purposes without increasing any risk. So especially in settings with limited resources, then you need to ensure that you try to use what is available at your level, but making sure that you adapt it in a way that you don't expose the staff. Regarding PPE, I know that some of the PPE may be reusable, for example, face shield, but then after use, it must be appropriately disinfected before it can be used again. But what I found in my setting generally is that sometimes people use masks for a very long time and even reuse them without proper disinfection, and that is really unacceptable. So my recommendation is that managers of health facilities, they should ensure that they provide those supplies, for example, like masks. They should be available to the staff. Otherwise, when the staff, for example, are contaminated and you quarantine or you isolate them for 10 days or 14 days, as the case may be, or if they end up in an isolation unit, you will have to spend more. So the best way to prevent from spending too much when the staff is infected is to ensure that you provide the protective equipment that are necessary for them to use on daily basis. Thank you, Lizzie.
Thank you, Jacob. Any additions from the panel? All right, I will move on to the next question, which is directed to Dr. Weber. And would it be appropriate to do steam sterilization at the beginning before manual handling as a precautionary measure, followed by the final steam sterilization, that is manual cleaning or final steam sterilization? I don't know whether the question is clear to you.
It is. We don't sterilize initially, then clean and re-sterilize. We first clean, and again, that can be done ideally in a washer disinfector. One could argue doing sterilization first reduces the risk to healthcare providers, but they're carefully trained. They're all in personal protective equipment. And if you sometimes, if you sterilize first before you've cleaned, you actually fix some of the material, blood and proteins onto the devices. So the goal here is first immediate cleaning to remove blood and any body fluids, then transport immediately to central sterile services, then meticulous cleaning or using a washer disinfector, then sterilization. Thank you.
Thank you, Dr. Weber. And another question directed to you is how are patients contributing to the effectiveness of the IPC practices in your facility? Over to you, Dr. Weber.
How are the patients? So we actually, as part of our, when a patient gets admitted to our hospital, provide them with a great deal of information. One of the things we encourage patients to do is if they see a healthcare provider coming into the room that does not has not performed hand hygiene, and of course they may have done it just outside the room, to ask their healthcare provider to wash or clean their hands. We also provide on the trays of food, we have a little alcohol wipe that they can use to wipe their hands before they eat. We have a whole variety of information sheets for patients about different organisms. So they'll get an information sheet that describes if they have what the impact of having say, methicillin-resistant staph or vancomycin-resistant enterococcus. So they're provided these information sheets about how they can better protect themselves with appropriate hand hygiene, surface disinfection, hand washing, for instance, for vancomycin-resistant enterococci after using the bathroom, et cetera. So we have a variety of information sheets. It's another way. And of course, for our patients, a number of them are Spanish speaking. So all of our information we give our patients is in both English and in Spanish. Thank you. Oh, I should say one other way we multiply our infection prevention department is we do have 20 people, which is a lot of people for infection prevention for our hospital our size. We have about 13,500 employees, and as I mentioned, 950 beds. But every area in the hospital has what we call an infection prevention liaison. These are people, mostly nurses, but not all, and they would be, for instance, in the radiology department in a specific unit like a pediatric intensive care unit, an endoscopy suite. So every individual unit, whether it's inpatient or a procedure type unit, has an infection control liaison. We meet with them monthly. We provide them every month a little lecture. We give them a chance to give us feedback. And what they do, it's a multiplier effect. So there are very knowledgeable people on each unit, and they help interpret our policies and guidelines for everyone on that unit. When there are problems, they bring them back to us because they know all the people in the infection and prevention department. And we find the use of these infection control liaisons very helpful in maintaining adherence to our policies and hearing about individual problems that we can help them fix in each of the individual units as well. Thank you.
Thank you, Dr. Weber. And one more question before I move to the other panelists. There is about 3 or 4 participants that are asking on the concentration of the hydrogen peroxide, which you use in your facility for the disinfection. Over to you.
So of course you have standard hydrogen peroxide that comes in different concentrations. Here the product we're using is what you call enhanced hydrogen peroxide. And what this does, and it's proprietary, so they've added different chemicals into the hydrogen peroxide that generate more free radicals, which is what is the inactivating substance. And we buy these already pre-prepared. Several companies make these so-called advanced or enhanced hydrogen peroxide products. We've tested in the lab, and they are much more active, as well as being very safe. And so that's the type of product we use, and it's pre-prepared. Thank you.
Thank you. And then the next question is, it's on the use of a surgical mask when collecting a COVID sample, whereby the patient isn't coughing. What time am I able to get infected? I think it's if it means you do not have a respirator and you're using the surgical mask, because what is the risk of getting contaminated or infected if you're collecting the swabs and putting on a surgical mask? Over to you.
Is that directed for me?
Yes, you may go ahead.
Yes, sure.
And answer.
Thank you. So
Dr.
taking a sample, mid-turbinate or nasopharyngeal sample is not considered an aerosol generating procedure. And so wearing a surgical mask, if properly worn, as well as obviously gloves. And we do now wear eye protection whenever having direct contact with patients, either a face shield or goggles. Or special glasses, that would not be considered an aerosol generating procedure. We've not had any of our healthcare providers develop COVID. Now, we do have what we call a respiratory diagnostic center where before a patient, when a patient goes to an outpatient facility like dermatology, they're asked about exposures or symptoms. And if they have symptoms comparable with COVID, cough, sore throat, headache, profound fatigue, fevers, they would be sent to the Respiratory Diagnostic Center first for a test before they would be seen. And the people in that Respiratory Diagnostic Center are wearing N95s and gowns as well as face shields. And that's where we prefer to do our testing. But in some of our clinics, if people arrive, they can get tested, and we just have those people in a regular surgical mask. Thank you.
Thank you, Dr. Weber, and thank you so much to the panelists for taking part in the Q&A. I'd like to hand over to Anna, but on the chat box, I've noticed there's quite a number of questions that basically asking about the survival of the coronavirus on surfaces. I don't know whether I know in the previous webinars we have addressed this and also looked at environmental disinfection. I'd like to find out from Anna if it's something that we can maybe get to relook so that we try and address some of the concerns or the questions that have been raised on the Q&A today. Over to you, Anna.
Thank you very much, Lizzie. Yes, and thank you very much, Dr. David and the panelists for attending today. Yes, I saw a lot of these questions, and we will definitely address some of these again in our next series that will start in about 2 weeks' time, Series 9. We're definitely going to have a session on decontamination as well. So, you know, I think we will look at all the questions that people are posting, and when we develop our new curriculum for the next series, we also think about that. So we will definitely address that. But that also to say that, you know, we've addressed this quite a few times. And I think part of this is what we want to say is that what Prof. Shadai said is just to have the knowledge doesn't always mean people understand how to implement. And that's maybe why this keeps on coming back. So we need to think about how we want to make sure that people understand and understood and know how to implement what we are giving them. A lot of people want to have the presentations and I think then they can take it from there, but it's sometimes not as easy. So we want to make sure that people do understand exactly what is needed from them, but we will definitely address these issues. So we will look into this and get back to them, and also about the survival. There was just one question, and I'm not sure if maybe Dr. David or Prof. Shadai could answer that. They ask about how long does it survive in a dead body. So I'm not sure if any of you have anything back on that. If you want to maybe answer Prof. Shadai or Dr. David.
Yes, so we know that SARS-CoV-2 survives on surfaces for minutes to hours. We also know it survives on hands for minutes to an hour or so. We know that it's easily killed on hands in just 5 to 10 seconds by alcohol antiseptics. I've not seen any data how long SARS-CoV-2 would survive in a dead body. Certainly, viruses are internal, and so as long as there was some cells surviving that might contain virus, it would survive there. But I don't actually know. We certainly treat any dead body as potentially contaminated if one was doing an autopsy and have people in appropriate personal protective equipment. But I haven't seen, it's a good question. I haven't seen any data on survival in that case.
Thank you very much. And I want to just thank Lizzie as well for taking us through the question and answer. Thank you for the panelists to spend the time here. And thank you very much, Dr. David, for this brilliant presentation. And we just want to also, a lot of people want to know if they can get your presentation. So if you're willing that we can share the PDF version to them, you can just let us know, and then we will be able to share it with them. But I think, you know, sometimes one have to really walk them through, because you said a lot of things that are not on the slides. And I think it's important to have all that as well. So from my side, thank you very much. And I really appreciate getting up this early and spending time with us and really walk us through this. This was a brilliant lesson for all of us and a brilliant eye-opener as well. Thank you very much.
Thank you, and you are free to share my slides with anyone who wants them.
Thank you very much. We will do that. I just want to also remind everybody that we will do our final session next week, Wednesday, at the same time. And we're going to look at other special services like the laboratories and the emergency services and maybe waste management as well. And then we will have 1 week break and then move forward to Series 9, which will also run over 6 weeks. And we will have a curriculum developed for that. So if there's anything that are really pressing, please let us know and we can see if we can handle that. And just another reminder, on a Thursday, we have the French version of what is happening here as well. And for our French people, they can attend that. That is normally at 2 o'clock South African time. So, 1 o'clock South African time and 2 o'clock East Africa time. So if you are willing to or wanting to rather attend the French one, that is also possible. So thank you very much and have a good afternoon. And thank you again, Dr. David. Have a brilliant day and thank you for your participation.
Thank you all.
Thank you. Goodbye.
Goodbye.
Recording stopped.